In this video, we demonstrate how diagnosis of one type of occult subscapularis tear may require takedown of the medial biceps sling. This is a right shoulder as seen with a 30-degree arthroscope from a standard posterior viewing portal. There is an obvious full-thickness tear of the supraspinatus, which extended much further posteriorly. Directing our view anteriorly, we see the upper subscapularis border and biceps tendon. We find this typical view with a 30-degree arthroscope to be inadequate for thorough inspection of the subscapularis tendon and biceps. Thus, at this point, we routinely switch to a 70-degree scope. The 70-degree arthroscope gives a bird's eye view over the top of the subscapularis tendon and down the biceps groove. At this point, we have our assistant perform a posterior lever push maneuver, which allows visualization of the majority of the subscapularis footprint, especially the broad upper tendon insertion. Even with this enhanced view, inspection of the footprint shows no overt tear. As we view farther laterally, the torn biceps sling is seen. Tissue loss of the anterolateral sling and biceps instability are noted. No tear of the medial sling sidewall is visible, which can be another sign of an occult subscapularis tendon tear. With these arthroscopic findings, we made the decision to perform a biceps tenodesis. At this point, the biceps has been tenotomized and prepared for tenodesis. Debridement of pathologic tissue enhances the field of view and reveals linear longitudinal splits in the tendon, indicating subcoracoid impingement. Given our strong suspicion for occult subscapularis tendon tear, and that the medial sling was no longer going to be required for biceps stability, we made the decision to take down the capsulo-ligamentous tissues forming the medial biceps sling to better visualize the subscapularis tendon fibers. A right curved scissors was used to carefully incise the sling. This revealed a nearly full-thickness tear of the upper 50% of the subscapularis tendon. Meticulous bone bed preparation is carried out using shaver, electrocautery, ring curettes, and high-speed burr. Subcoracoid decompression follows bone bed preparation, and a large coracoid osteophyte was debrided and removed with high-speed burr. This step is not shown. Next, 2 fiber tape sutures are sequentially passed antegrade through the subscap tendon using a scorpion suture passer. Using an anterior portal, a socket was created for a 4.75 mm biocomposite swivel lock C anchor. The fiber tape sutures are passed through the eyelet of the swivel lock anchor and the anchor placed into the bone socket, completing a knotless repair. The fiber tape suture tails are then cut. Here we see our completed, knotless medial repair, which achieves secure anatomic fixation of the subscapularis tendon to its footprint. Next, we place a guide pin at the juxta-articular margin of the humeral head and drill our 8 mm bone socket for the tenodesis. Using the tenodesis driver, the biceps tendon is placed into the bone socket and secured. The tenodesis sutures would later be incorporated into the supraspinatus repair.